Welcome to the Deep Dive, where we take the dense, authoritative literature that shapes clinical practice and really distill it down into the essential, unforgettable knowledge that equips you for what's next.
And today we're undertaking a monumental task.
We really are. We're aiming to master the entire field of elective orthopedics of the upper limb, all based on Chapter 38 of the classic surgical text, Bailey and Love.
This deep dive is designed specifically for, efficiency and retention. We know this chapter is just packed with detail, from nuanced anatomy to really complex surgical indications.
So our mission is what, exactly?
Our mission is to extract those critical anatomical fundamentals, the clear-cut diagnostic criteria, and the definitive treatment pathways for every common condition you'll see: shoulder, elbow, wrist, and hand.
Think of this as your accelerated path to, well, comprehensive clinical knowledge in this area.
Exactly. We're translating those dense paragraphs into clinically useful insights.
And we have two major learning objectives today, straight from the source. First, we need to solidify that core anatomy and physiology. I mean, you can't fix a mechanical problem if you don't understand the machine.
And second, we will ensure you can not only explain the diagnosis, but also articulate the standard and, the alternative treatment plans for all those common conditions, from adhesive capsulitis all the way down to Dupuytren's contracture.
Our roadmap for this is, I think, very logical.
Yeah.
It follows the limb geographically, which helps a lot with revision. We're starting high with the complex mechanics of the shoulder girdle.
Then we'll move distally to the elbow, and we'll finish up with the highly nuanced and functionally critical hand and wrist.
Okay, let's jump right in. The shoulder, let's talk about movement.
The shoulder is just unique in the human body. It's designed for a maximal range of motion, and that requires this incredible feat of coordinated engineering.
Right.
The first foundational fact we have to lock down is the structural connection point.
Okay, so let's unpack that. You've got the scapula, the humerus, the clavicle all moving together. But what's the single biggest anatomical takeaway here?
It's the sternoclavicular joint. That tiny joint connecting your clavicle to your sternum is the only synovial joint that anchors the entire upper limb to the rest of the axial skeleton, to your trunk.
So everything else is just balanced by muscle.
Everything else is balanced, tethered, and controlled by muscles. And that reliance on soft tissue rather than, bone-on-bone stability, it explains almost all the pathology we see.
That makes perfect sense. Because it relies on muscle control, it needs this really complicated chain of motion to get a full range. So if we look at achieving a full 180 degrees of elevation, lifting the arm straight overhead, it's not all happening at the main ball and socket joint, is it?
No, not at all. It's a synchronized dance, often called the scapulohumeral rhythm. Only about, say, 120 degrees of that happens at the glenohumeral joint itself.
So the rest, that crucial 60 degrees, comes from other components.
That's right, and the source breaks it down. Roughly 50 degrees comes from the rotation of the scapula gliding over the rib cage, the thorax.
Okay.
And at the same time, the clavicle itself elevates somewhere between 30 and 60 degrees at that sternoclavicular joint.
It's a fully integrated system that just demands precision.
And that precision is maintained by the rotator cuff, the RC. Now, there are 26 muscles acting across the shoulder, but the RC is the core dynamic stabilizer.
We have to name them.
We do. Subscapularis, that's anterior. Supraspinatus, superiorly. Infraspinatus, posteriorly. And then teres minor, which is postero-inferior.
And their essential job is centralization.
Exactly. Keeping the humeral head focused against that shallow glenoid socket, preventing it from just migrating upwards when you contract the huge deltoid muscle.
And here's where anatomy connects directly to pathology, the clearance mechanism. We all know you have to externally rotate the humerus when you raise your arm. Why is that?
Because the greater tuberosity, that bony prominence on the humerus where most of the RC attaches, it needs to pass under the bony shelf of the acromion and the coracoacromial ligament.
Right.
If you try to lift your arm in pure internal rotation, that greater tuberosity just slams right into the acromion. It's a mechanical block.
So external rotation is the key. It's the maneuver that rotates the tuberosity out of the way, giving you the clearance for full elevation.
And if that mechanism fails, you get impingement. Simple as that.
Okay, so before we dive into acquired problems like impingement, let's quickly touch on a couple of developmental issues that can, masquerade as acquired injuries. Starting with the commonest one, Sprengel's shoulder.
Sprengel's is a failure of normal embryonic development. The scapula starts up in the midcervical region, and it's supposed to descend.
And in this condition, it just doesn't.
It fails to descend fully. So what you see is a scapula that's high, visibly small, and rotated.
And the most fascinating clinical detail, the thing that's critical for diagnosis, is the potential for an omovertebral body.
Yes, a connection between the scapula and the cervical spine. It could be a fibrous band or even a solid bony bar. Its presence is key, and it often correlates with other cervical issues like Klippel-Feil syndrome,
And the other congenital issue.
pseudarthrosis of the clavicle. The key clinical trap here, which the source explicitly warns about, is mistaking this for a non-union after a traumatic fracture.
Like a birth fracture.
Exactly, one sustained at birth. And attempts to treat this congenital lesion with standard fracture fixation plating, grafting, they are almost always unsuccessful.
Because it's a developmental anomaly, not a failure of healing.
Precisely. It's a non-traumatic anomaly that just mimics a fracture complication, and it often presents in childhood.
Okay, now for the main event. Acquired shoulder pathology.
Okay.
This is the vast majority of what we see. Let's start with assessment, because a thorough history is often more revealing than the exam itself.
That's so true. Beyond the standard, onset, duration, and patient profile, the diagnostic priority is establishing whether the pain is genuinely local or if it's referred.
So you have to ask about the neck.
Always. You must always inquire about neck problems because a cervical radiculopathy can mimic shoulder pain exactly.
So what's the clinical pearl from our source to differentiate local shoulder pathology from referred neck pain?
It's precision. If the patient can localize their pain to an exact point around or within the shoulder, say right over the greater tuberosity or deep in the joint, it is highly unlikely to be referred from the neck.
Because referred pain is usually diffuse, vague.
Exactly.
Okay, so once we suspect it's a local shoulder problem, we rely on maneuvers to isolate the structure. For impingement, we use tests that forcefully narrow that subacromial space.
Right. And the classic example the source mandates we know is Hawkins's test.
How does that work?
So Hawkins's test is done with the shoulder flexed 90 degrees forward, and then you internally rotate the arm. This jams the greater tuberosity and the rotator cuff attached to it directly under the acromion and the coracoacromial ligament.
And if that reproduces that sharp characteristic pain, the test is positive.
It is. Other tests, like the apprehension test, are for instability, which we'll get to later.
Okay, investigations. We mentioned that radiographs are limited because they don't show soft tissue, but they aren't useless. What are we looking for on plain x-rays?
A few things. Primarily, we're checking for chronic changes. A reduced subacromial space is a powerful indicator of a full-thickness rotator cuff tear.
Why is that?
Because without the cuff holding the humeral head down, the deltoid just contracts unopposed and pulls the head superiorly. We also look for acromial spurs or AC joint arthritis.
And regarding those acromial spurs, the source focuses on the three common acromial morphologies: flat, curved, and hooked.
And it states that patients with impingement are significantly more likely to have that hooked acromion.
But then it throws in this fascinating piece of nuance about causation.
It does. The long-standing theory was that the hook caused the impingement. But the source suggests the spur may actually be a secondary effect, not the cause.
So it might arise from degeneration or calcification within that coracoacromial ligament insertion.
Making it a result of the same degenerative process that's weakening the cuff rather than the primary mechanical agent of destruction. And this changes the whole rationale for surgical decompression.
So to assess the soft tissues, we need to go beyond x-rays. What are the key imaging modalities?
Ultrasound is excellent. It gives you a dynamic, real-time assessment of the rotator cuff and any fluid in the bursa. MRI gives you better detailed anatomical pictures, checking cuff integrity and overall health.
And if you're suspicious of a labral tear?
If you're highly suspicious of a labral tear or some subtle instability, then you need an MR arthrogram where dye is injected into the joint to really highlight those structures.
Let's talk about the ultimate diagnostic tool for impingement, Neer's test.
Right. Neer's test uses a local anesthetic injection to confirm the source of pain. The patient initially has a painful arc on forward elevation, that's Neer's sign.
Okay.
If, after you inject local anesthetic into the subacromial bursa, the pain is completely relieved and the arm can now be passively lifted through that arc pain-free.
The test is positive.
The test is positive, confirming the pain generator is strictly that inflamed bursa and cuff.
This moves us perfectly into the pathology itself: rotator cuff degeneration and impingement, which the source frames as a vicious circle. Why is the rotator cuff so uniquely prone to age-related degeneration?
The source gives 3 fundamental reasons. First, the mechanical environment. It's operating in that really confined space.
Between the humeral head, the acromion, and the ligament.
Exactly. Second, the blood supply is poor. When the tendon is stretched or tensioned, the blood vessels get compressed, restricting inflow. And third, because of this, it has a very limited capacity for self-repair.
So that structural vulnerability means even a trivial injury can start the whole process.
Yes, the injury inhibits smooth gliding, which leads to inflammation and swelling impingement, which causes more pain.
Which in turn causes the patient to use the arm incorrectly, further inhibiting gliding.
And there's your vicious circle.
Clinically, this shows up as the painful arc.
The pain is worse between 60 and 120 degrees of abduction. But the critical distinction for you to remember is that while the active movement is painful, the examiner can usually passively lift the arm through that arc once the impingement area is cleared.
And that differentiates simple impingement pain from true structural weakness, like a tear.
Precisely.
So treatment aims to halt that inflammation cycle. We start non-operatively with physio, anti-inflammatories, and often that local corticosteroid injection into the bursa.
And if that fails after several months, then surgery is considered.
And arthroscopic subacromial decompression, removing the spur, the anteroinferior acromion, and the CLL.
But, and this is a huge but, we have to reiterate the key clinical caveat from the source.
We do. While the surgery provides good short-term symptom relief, there is no robust evidence that it alters the long-term prognosis or prevents the eventual development of a future rotator cuff tear.
It manages the pain, but not necessarily the underlying degenerative inevitability.
You've got it. And that leads us to rotator cuff tears, which are essentially the end stage of this process. And these tears, they do not heal spontaneously.
No, they don't. And their prevalence is shocking.
It is.
The source notes that between 4 and 20% of people in their 40s and 50s already have asymptomatic RC tears. By age 70, up to 30% have asymptomatic full-thickness tears.
Which really underscores that age is the dominant factor, often independent of any acute trauma.
Absolutely. The mechanism of the tear typically starts as a small defect, anterolaterally in the supraspinatus, and then it progresses posteriorly. As it enlarges, the muscle retracts medially, leaving this large, bare area of bone over the greater tuberosity.
In terms of diagnosis, if you do that local anesthetic injection, the NEERS test, and the pain is gone, but the weakness persists.
You know you have a significant tear. Clinically, you'll see weakness, limited active abduction, muscle wasting, and the patient often compensates by visibly hunching their shoulder to start the movement.
And the definitive test for the supraspinatus is the empty can test.
Right. Classification is just by size: small, intermediate, and large. And treatment is highly individualized.
It has to be.
For a young, highly active patient or someone who has an acute traumatic tear with a sudden loss of function, early repair gives the best results. But the decision is heavily constrained by recovery time.
It's a huge investment.
It is. Post-repair rehab requires 3 to 6 months before the patient can resume full overhead and heavy-duty loading. This dictates which patients are even suitable for repair.
And for those chronic massive tears where you have retraction and fatty atrophy, I mean, the muscle is basically useless at that point.
Simple reattachment is futile. This is when the surgeon has to look at complex reconstructive options: tendon transfers, patch grafts, or, if the joint is severely involved, a reverse shoulder replacement.
Okay, let's move on to inflammatory and stiffness-based pathologies, starting with a classic clinical entity, frozen shoulder, adhesive capsulitis.
This one is idiopathic, no clear cause, and it tends to affect women in their 50s. And crucially, it has strong associations with systemic diseases.
Diabetes mellitus, particularly, but also heart and thyroid problems.
Yes. The presentation is characterized by 2 distinct stages: severe pain initially, often after some minor event, followed by profound global stiffness.
And here is the absolute diagnostic feature that separates this from everything else: a global loss of both active and passive movement.
It's limited by pain, but the stiffness is structural. It's rigid.
And the pathognomonic sign, the one that tells you instantly it's adhesive capsulitis and not something else, is the near complete loss of active external rotation.
And your radiographs will be normal, confirming it's purely a soft tissue, a capsular problem.
The natural course is slow, but often benign. It typically resolves spontaneously over 1 to 2 years, though it can linger much longer in diabetics.
Treatment starts with pain relief in that initial painful phase. Once the freezing phase is established, it's physio, corticosteroid injections, and often distension injections.
Which is where you inject a large volume, 20 to 30 ml of local anesthetic and saline into the joint capsule to physically stretch and break up adhesions.
Exactly, to facilitate better movement. For resistant stiffness, you might do a manipulation under anesthesia or an arthroscopic capsular release to speed things up.
Now let's contrast that with calcific tendinitis. This involves calcium salt deposition, usually in the supraspinatus tendon.
Believed to be part of an underlying degenerative response. The clinical spectrum is wide. You can find these deposits incidentally on X-ray with no symptoms at all.
Or the patient can present with acute calcific tendinitis, which is agonizingly painful, often restricting all motion. Imaging shows these florid, dense, opaque lesions.
Right, but what's the clinical distinction from the frozen shoulder we just talked about?
Well, unlike frozen shoulder, in calcific tendinitis, the patient often retains the ability to perform external rotation.
The restriction is from pain and inflammation, not a globally fibrosed capsule. And like frozen shoulder, it's often self-limiting as the body eventually resorbs the calcium.
Treatment options include subacromial steroid injections, but the more unique interventions are needling or barbotage.
Which is essentially aspirating and flushing the calcific material out of the tendon under ultrasound guidance. For persistent, severe pain, surgical excision is still an option.
Okay, moving to the destructive conditions, arthritis, starting with rheumatoid arthritis, RA.
The glenohumeral joint is frequently involved. The pathology is driven by that inflammatory synovial tissue, the pannus, leading to cartilage destruction, bone loss, and, very importantly, a high incidence of secondary rotator cuff tears.
The source notes that while arthroscopic synovectomy was once common, modern biological therapies have really changed the landscape. But when joint replacement becomes necessary, the complexity is immense.
It is. You're dealing with poor bone quality and frequently a damaged or completely deficient rotator cuff. If the cuff is deficient, which is often the case in late-stage RA, an anatomical replacement is compromised.
So the surgeon has to opt for a specialized procedure.
The reverse shoulder replacement. This effectively switches the ball and socket. You put the socket on the humerus and the ball on the glenoid.
So it relies on the large deltoid muscle rather than the deficient rotator cuff to power elevation.
Precisely. It offers excellent pain relief and a much better chance of restored range of movement in the setting of cuff deficiency.
Then there is osteoarthritis, or OA. This could be primary, secondary to trauma, or the result of chronic, massive rotator cuff disease.
Which we call cuff arthropathy.
Right, and cuff arthropathy is that distinct end-stage picture where the massive cuff tear allows the humeral head to migrate superiorly, grinding away the acromion and the glenoid.
The surgical decision, as highlighted in the source's summary box, hinges entirely on the health of the rotator cuff. This is the crucial determinant.
So if the patient has an intact, functional rotator cuff,
then the preferred surgery is the anatomical total shoulder replacement. You replace the ball and the socket. This offers better pain relief than just replacing the ball, which is a hemiarthroplasty.
Conversely, if the rotator cuff is deficient, which applies to most RA patients and all cuff tear arthropathy patients, the choice pivots
to either a hemiarthroplasty or, more commonly and with better functional results, the reverse polarity total shoulder arthroplasty.
But we have to remember, while replacement gives excellent pain relief, restoring full, powerful motion, especially above the shoulder, is less predictable.
Absolutely. Finally, there's the option of arthrodesis, or joint fusion. This is generally reserved for younger patients with severe pre-existing problems like sepsis or profound neurological deficits, like a major brachial plexus injury.
And the prerequisite for a successful arthrodesis is functional scapulothoracic control. The patient has to be able to powerfully shrug their shoulder.
Yes. And the functional outcome is surprising. The patient retains fair motion, but it's entirely derived from that scapulothoracic movement, which accounts for about 1/3 of normal elevation. You sacrifice glenohumeral motion for a strong, stable, and painless platform.
Okay, let's shift focus to instability. The source provides a wonderfully clean classification into 3 groups, which is essential for figuring out the treatment pathway.
This classification is your roadmap: traumatic T, atraumatic A, and habitual H.
Okay, T, A, and H.
Traumatic instability is unidirectional, usually anterior, it's involuntary, and surgery tends to be highly successful.
And traumatic.
That's multidirectional, painful, also involuntary, and it responds to rehab first, then maybe surgery.
And the third one, habitual, is the one you treat completely differently.
Right. This is voluntary, typically painless, often associated with generalized ligament laxity, and, crucially, Surgery is usually contraindicated because of its high failure rate.
The commonest clinical presentation is recurrent traumatic anterior instability. This usually happens to people under 25, starts with a significant traumatic event, and then subsequent dislocations require less and less force.
Yes, the shoulder dislocates anterior-inferiorly. Diagnosis relies on the apprehension test. When the examiner puts the arm into that vulnerable position, forced abduction and external rotation, the patient gets that distinctive anxiety.
That feeling of impending doom, anticipating the shoulder, will pop out.
Exactly. The trauma often causes specific structural damage we look for on imaging. The two classic lesions are Bankart's lesion and Hill-Sachs lesion.
Bankart's is the detachment of the antero-inferior labrum from the glenoid rim, and a bony Bankart includes a fracture of the glenoid margin.
And the counter lesion, the Hill-Sachs, is an impaction injury on the posterolateral aspect of the humeral head, caused when the head bangs against the sharp anterior glenoid rim during the dislocation.
Treatment for this highly recurrent traumatic type is usually surgical, either arthroscopic or open, to repair that Bankart lesion and tighten the capsule, and it's very successful.
It is. Prevents recurrence in 90 to 95% of patients. If there are large bony defects, though, especially of the glenoid, simply repairing the soft tissues isn't enough, and you might need complex bone grafting procedures.
Now for the diagnostic trap. Posterior dislocation. It's rare and it's often missed, making it the hidden danger in shoulder trauma. What history should raise our index of suspicion immediately?
Anything involving severe, uncontrolled muscle contraction coupled with forced internal rotation. So think electric shock, a seizure, or severe restraint, like a half-Nelson wrestling move.
And if the patient has been unconscious or unable to give a history, you have to rule it out.
Always. And the radiographic trap is crucial. The standard AP view can be misleading.
Why is that?
The AP view can look deceptively normal because the humeral head is just shifted posteriorly. It might show the subtle light bulb sign. The humeral head looks spherical because it's internally rotated and locked.
So the axial projection is absolutely critical.
It's the only view that definitively shows the anteroposterior relationship and confirms the posterior displacement.
Treatment can be challenging, especially if it's a chronic or locked posterior dislocation. After you reduce it, the management is all about protecting the healing posterior capsule.
Correct. Post-reduction, the shoulder must be immobilized in an external rotation brace, placing that posterior capsule in a relaxed position to let it heal. The exact opposite of what you do for a typical anterior dislocation.
Let's quickly contrast the atraumatic and habitual instability types. Atraumatic is often multidirectional, with subluxation partial slipping being more common than full dislocation.
These patients often have generalized ligament laxity, which you can check with a simple screen like the Batten score. Clinically, they show apprehension in multiple directions, and the classic sign is the sulcus sign,
where you apply inferior traction to the arm and the deltoid muscle dips visibly into the gap created by the subluxation.
Right. Treatment here starts conservatively, with highly specialized physiotherapy, retraining muscle firing patterns, improving proprioception. Surgery is only for severe failure of rehab.
And for habitual instability, the voluntary, painless party trick.
The advice is simple: stop doing it. Physical therapy may help, but the key takeaway is that surgery is definitively avoided due to the historically high rates of failure in this group.
Okay, moving down the limb to the elbow. Unlike the shoulder, the elbow trades mobility for essential stability. It's a tight, compact joint.
It deals with two main functional axes, flexion and extension at the ulnohumeral joint, and then rotation, pronation, and supination at the radiocapitellar and proximal radioulnar joints.
And understanding the neurovascular map here is non-negotiable.
It really is. The source emphasizes the structures in that thin, soft tissue envelope. Anteriorly, from medial to lateral, you find the median nerve, the brachial artery, and the radial nerve.
And posteriorly, tucked right behind the medial epicondyle, is the vulnerable ulnar nerve. Let's look at arthritis, starting with rheumatoid arthritis, RA, which leads to end-stage destruction. What are the main surgical options?
The goals are pain relief and restoring function. For patients with restricted pronation and supination, but decent flexion and extension, a simple arthroscopic or open radial head excision and synovectomy can be very effective.
And if the whole joint is shot?
If the entire joint is severely destroyed, then a total elbow arthroplasty is the standard approach. It offers good pain relief and functional gain.
Contrast that with osteoarthritis, OA. This is typically primary or post-traumatic, classically affecting middle-aged men in manual occupations.
The clinical presentation of OA involves pain, crepitus, locking, and a major loss of terminal flexion and extension from osteophytes. But, crucially, compared to RA, the joints responsible for rotation, pronation, and supination are often spared.
So surgical treatment for OA depends on the demands of the patient. For most cases, it's a surgical debridement, a lateral column procedure.
Right, to remove osteophytes, thicken capsule, loose bodies. This alleviates pain and restores motion.
And arthroplasty.
It provides predictable pain relief, but the source explicitly warns that high activity levels lead to early loosening. Arthrodesis, fusion, is very rarely offered because it results in such a significant functional loss.
Speaking of mechanical symptoms, loose bodies are a hallmark. What causes them, and what's the cardinal symptom?
They're caused by OA, trauma, osteochondritis dissecans Panner's disease in the young or synovial chondromatosis. The key symptom is sudden, sharp pain and mechanical locking. The patient often has to manipulate their arm to get relief.
And treatment is usually arthroscopic clearance.
Highly effective.
Now, for the painful swelling that constantly comes up, olecranon bursitis, a red, warm, swollen, painful fluid collection right over the pointy end of the elbow. How do you differentiate this from a true septic joint infection?
The differentiation is purely anatomical and functional. In bursitis, the swelling is strictly confined to the extensor aspect over the olecranon, outside the joint capsule.
So joint motion is often preserved.
Exactly, specifically within that 30 to 130 degree functional arc. If the patient has a septic joint, the inflammation is intra-articular, and any movement will cause exquisite pain and stiffness.
Okay. If the bursitis looks purulent or the patient is pyrexial, then drainage and antibiotics. And finally, the most common nerve entrapment here, ulnar nerve compression, or cubital tunnel syndrome. Where is the nerve most commonly trapped?
Most commonly, right in the cubital tunnel behind the medial epicondyle. But also, you have to look for compression higher up, within the arcade of Struthers, or distally, where the nerve runs between the two heads of the flexor carpi ulnaris muscle.
Symptoms are classic.
Yeah.
Tingling and numbness in the little finger and the ulnar half of the ring finger, progressing to wasting and weakness of the small intrinsic hand muscles.
The key signs include a positive Tinel's sign percussion over the compression site reproduces the tingling. And to assess intrinsic muscle function, we rely on Froment's sign,
which tests the adductor pollicis muscle.
That's right. If the adductor is weak, the patient compensates by flexing the flexor pollicis longus muscle of the thumb to maintain a pinch grip on a piece of paper.
Treatment starts conservatively with night splints to prevent elbow flexion. If that fails, surgery is indicated. What determines the specific surgical approach?
Simple nerve decompression is usually sufficient. However, if the patient has a pre-existing valgus deformity that stretches the nerve, or if the nerve is unstable and tends to subluxate after decompression, then you perform an anterior transposition.
Where you move the nerve out of the cubital tunnel to the front of the elbow to reduce tension.
Exactly.
Okay, we have arrived at the final, most complex anatomical structure, the hand and wrist. Before anything else, the assessment must be meticulous. Function here is defined by millimeters.
History is everything here. You need to detail occupation, hobbies, hand dominance, because they define the functional requirements. But the essential question for the surgeon is, what symptom pain, stiffness, swelling is truly causing the functional deficit?
Exactly. For motor testing, quick checks are crucial. Test the abductor pollicis brevis for the median nerve and the first dorsal interosseous for the ulnar nerve.
And sensory mapping. Median nerve for the radial 3.5 volar digits, ulnar for the ulnar 1.5, and the radial for the dorsal first web space.
Let's discuss the arch enemy of hand surgery and rehabilitation, swelling and stiffness. Why is this such a disaster?
The hand naturally adopts a position of comfort after injury. Wrist flexed, MCPJs extended, IPJs flexed. If this position is allowed to persist, the collateral ligaments, particularly around the MCPJs, shorten and the joint capsule's fibrous,
Locking the hand into a functionally useless claw-like posture.
Yes. So the prevention strategy is absolutely critical. Elevation to reduce swelling, early movement where possible, and most importantly, splintage in the position of safety.
Also known as the Edinburgh position.
Right, which is wrist extension, MCPJ flexion to about 70 degrees, and IPJ extension. This keeps those collateral ligaments of the MCPJs maximally stretched and prevents them from shortening, preserving your ability to make a functional grip later.
Okay, moving into acute injuries. Let's start with the thumb's key stabilizer. The ulnar collateral ligament, the UCL. Chronic laxity is gamekeeper's thumb. Acute trauma is skier's thumb. What makes a full UCL tear a surgical emergency?
If valgus stress testing shows significant joint opening, surgery is mandatory. This is because the adductor aponeurosis gets trapped between the torn ends of the ligament, a Steiner lesion, physically preventing the ligament from healing. You have to surgically retrieve it and repair it.
And on the wrist, the triangular fibrocartilage complex, or TFCC, which stabilizes the distal radial ulnar joint.
Tears present as ulnar-sided wrist pain and instability. Peripheral tears, usually traumatic, are often vascularized and can be repaired. Central degenerative tears are usually avascular and are managed by arthroscopic debridement.
Now for the common tendinopathies. Trigger digit, a mismatch between the flexor tendon and its sheath, usually at the A1 pulley. The patient describes painful locking or snapping.
Treatment starts with a corticosteroid injection into the flexor tendon sheath. If that fails, a surgical release of the A1 pulley is performed, which immediately solves the mechanical problem.
The other common one is de Quervain's disease, inflammation of the sheaths containing APL and EPB in the first dorsal compartment, often called new mother's wrist.
The definitive diagnostic test is Finkelstein's test. The patient makes a fist with the thumb inside, and the examiner passively performs ulnar nervation of the wrist. This produces immediate severe pain.
Treatment is splinting, injections, or surgical release, where you have to ensure every single tendon slip is fully decompressed. Let's shift gears to a non-negotiable surgical emergency. Hand infections. Start with the common ones.
Paronychia, the nail bed infection, is the most common, treated with incision, drainage, antibiotics. A felon is an abscess in the fingertip pulp with a high risk of osteomyelitis. It needs aggressive incision and drainage through the midline pulp pad and IV antibiotics.
But the critical emergency that demands immediate attention is a flexor tendon sheath infection. The diagnosis relies on the 4 highly sensitive Canvell's cardinal signs. What are they?
1. The affected finger is held rigidly in flexion. 2. There is uniform fusiform swelling over the entire tendon sheath. 3. It is exquisitely tender to touch along the sheath. 4. There is severe pain on any attempt at passive expansion of the finger.
If you see those 4 signs, the window for intervention is extremely small to prevent tendon necrosis. We also have to understand the anatomy of spread.
We do. Infections in the central digits, 2, 3, and 4, are usually contained. But infections in the thumb or little finger can spread proximally into the wrist and palm via the radial and ulnar bursae.
Complicating the washout significantly.
It does. Treatment is aggressive. Open irrigation and debridement, extended 5E antibiotics, and early, carefully monitored mobilization to prevent adhesions.
Moving to chronic destruction. Hand arthritis, starting with rheumatoid arthritis, RA, driven by that erosive pannus.
RA creates classic deformities. The fingers commonly present with a boutonniere deformity, PIP flexion, DIP extension, or a swan neck deformity, which is the opposite.
At the wrist and MCPJs, we see radial drift of the wrist, compensated by the characteristic ulnar deviation of the MCPJs, and extensor tendon ruptures, often starting at the little finger.
The surgical strategy for RA is meticulous. Start proximally and work distally. Indications are pain relief, functional improvement, and preventing further deformity. Procedures include synovectomy, nerve decompression, arthrodesis, or joint replacements.
In sharp contrast, osteoarthritis, OA, in the hand is commoner in females, and it targets specific joints. The source highlights the DIPJs, forming Heberden's nodes, the PIPJs, forming Bouchard's nodes, and critically, the thumb CMC joint.
Treatment for OA starts non-operatively. For the DIPJs and PIPJs, if pain is severe, arthrodesis is often preferred. You sacrifice motion to eliminate pain.
And for the incredibly common and painful CMC joint arthritis,
the gold standard surgical treatment is excision arthroplasty, specifically a trapeziectomy, where you excise the trapezium bone. This creates a space, often filled by a tendon sling, reducing pain and allowing for stable pinch function.
Let's cover the final classic pathology, Dupuytren's contracture. The profile here is key. Autosomal dominant, overwhelmingly Northern European men in their 50s to 70s.
It's a fibroblastic hyperplasia, forming nodules, skin puckering, and digital cords that pull the fingers into fixed flexion contractures, most commonly on the ulnar side.
It has strong associations with smoking, diabetes, cirrhosis, and epilepsy. And the associated features outside the palm are Gerard's knuckle pads, Peyronie's disease, and Lederho's disease in the foot.
The critical indicator for intervention is functional loss. This is defined by failure of the simple tabletop test. The patient cannot lay their hand flat on a table or any significant contracture at the PIP joint.
Treatment for milder cases includes needle fasciotomy or collagenase injections. Severe cases require surgical excision of the cord, a fasciectomy, which is technically challenging because of the risk to the digital nerves.
And due to the skin shortage, the surgeon often needs to use Z-plasties or skin grafting for closure. In very late stage fixed contractures, amputation may even be required.
Finally, a quick mention of structural failure related to blood supply, a vascular necrosis, AVN, and cysts.
Idiopathic AVN of the wrist bones includes Kienbuck's disease, affecting the lunate, and Preiser's disease, affecting the scaphoid. Both lead to progressive collapse and secondary arthritis. For end-stage disease, treatment is often wrist fusion to provide a strong, stable, painless wrist.
And the most common hand swelling of all, ganglion cysts.
Typically found on the dorsal or volar wrist, or as a mucus cyst over a DIP joint, they're smooth, fluctuant, and they transilluminate brightly.
They can be aspirated or surgically excised, but the crucial clinical detail to remember is the high rate of recurrence with both treatments. You have to communicate that clearly to the patient.
I do.
We have completed an exhaustive review of elective upper limb orthopedics, from the subtle mechanics required for full scapulohumeral elevation through the differential diagnosis of elbow stability and down to the immediate recognition required for Canneval's signs in the hand.
The strength of this source material is its emphasis on pattern recognition, understanding of the 3 types of instability, the clinical distinction between frozen shoulder and calcific tendinitis, and matching the replacement strategy to the integrity of the rotator cuff.
And critically, we have seen that orthopedic management is a deeply functional decision. The approach is dictated not just by imaging, but by the patient's life demands, selecting arthrodesis for a high-demand laborer, or avoiding surgery entirely for a voluntary habit.
So let's close with a final provocative thought that really synthesizes the constraints we face in shoulder surgery. We discussed how anatomical replacements require an intact cuff, and reverse replacements are used when the cuff is deficient, but neither guarantees a full functional return.
We noted that arthroplasty is excellent at relieving pain, but it's less predictable in restoring power and motion, especially above shoulder level.
So think about your own daily routine. How often do you actively reach into a cupboard, wash the back of your hair, or lift anything heavy above 90 degrees?
All the time.
That necessary motion, which is powered by the precise synchronization of the rotator cuff, is often the most difficult thing to restore after joint destruction or repair. And this gap between eliminating pain and restoring that full functional arc above the shoulder fundamentally defines the limits of what a surgeon can promise. It remains the central challenge in advanced upper limb orthopedics. It's what separates a painless arm from a fully useful one.
An outstanding reflection on the constraints of surgical repair. Thank you for joining us for this deep dive into the upper limb. We hope this comprehensive structure and detail serves you well in your revision and clinical practice.